Okay, and without wasting any further time, I'll invite the first speaker, Dr. Rupesh Agarwal. Dr. Rupesh is a well-known figure in the field of uvea, retinal imaging, and ocular trauma. He's a senior consultant at the Tan Tock Seng Hospital in Singapore, and he has more than 400 publications with expertise in ocular imaging and ocular trauma and uvea. Over to you, sir.
Thank you. Thank you very much, Ramesh, for having me here. And it's a real privilege. I keep missing out every year each section course, but this is the first time I'm in person here after we have attempted a few times. Okay. Hey, I see it's five, making it 8 minutes, right?
No, it's a 10-minute.
10 minute. Huh? Okay. Okay. So essentially, no conflict of interest related to this particular thing. We'll be covering a few spectrum of talk, and there might be some overlap, though Dr. Ramesh did try to get us together and make sure that there is no overlap. But I'm sure there will be overlap, but we'll try and see how we kind of choose out the exact information what we need. So just to give you an idea about the choroid, and it was not till 2012 that we were able to image choroid as well as we can do it now. And these were the early days of the choroid. And I somehow got interested in the choroid when I wrote my first ever grant for $10,000 to look into just the choroidal thickness in uveitis. I thought somehow it will be helpful. And we wrote a grant and 20 patients were captured, but we could not get much information. But then somehow I was working on imaging and all, and then Pierre Skin in Moorfields Eye Hospital and Adnan Tufil, they told me to use their software, and which was a very painful exercise because one imaging will take up to 1 hour or 2 hours of processing. So I was like, oh, this is taking a lot of time to process. But just to give you a background about why people are interested in choroidal imaging or what is unique about choroid is because it is one of the richly vascular area, tightly thermoregulated, and probably one of the highly vascular supply area of the entire body, not just the eye. And therefore, there was a hypothesis that a lot of diseases in the retina and in the eye is driven from the choroidal flow, and then that can lead to the challenges here. So choroid do play a role in physiological and pathological processes, and physiology we know, and also can be used as an imaging biomarker, and that is what was our hypothesis that we'll probably be able to understand from here. And therefore, when we started looking into the choroid, and we thought, okay, this was the early days when the paper came out, and this was looking into the segmentation of the choroid, and we thought we should dive deeper. So for some of the junior attendees or the students and residents, once you start thinking about it, any particular topic, you should dive deeper and do some literature review. So first we thought we should do literature review, and we got some of the best in this field, and I got to contact Jay that time, and Jay and I, we got together and we thought we should do a good review article on this thing. And with one of the student, Kara N, she wrote this article. And in this, we investigated what are the different ways choroid can be imaged. And we have histopathology, which is not possible, ultrasound, which we've been using in my residency when we try to do good ultrasound to look into the choroidal thickness, fundus fluorescein, indocyanine green angiograph. And those days, the OCT started coming up. We thought, okay, maybe let's focus on the OCT as the output for it. So we kind of ignore right now all the other things about imaging, the ICG or the ultrasound. So we'll focus on the choroidal imaging using the OCT. So this is the term which we coined in those days in 2014, 2015, called as choroidal vascularity index. And this one was after the paper published by Teiji Sakamoto and Sonoda from Japan, Tokyo. And they published in AJO in 2013. And they did not use the term, and then they did something different in their analysis, and ours was different. So we use luminal area upon the total choroidal area as the biomarker, and that we used it as the index called as choroidal vascularity index. Just to give you an idea about how did the term came up. So in this particular room, if the area of this room is X and the area occupied by all of us and in the chairs and everything is put together, then that's called as the area Y. So Y upon X gives you kind of the population density index of this particular room. So similarly here, the vessels divided by the total area given as the choroidal vascularity index. So based on population density index, the term was coined as choroidal vascularity index, which has now taken up in a big way. And these are some of the images from animal eyes, which has underwent laser, and we just thought we'll segment and then try and understand what's happening here. So these were the segmented images of the choroid, and we were trying to see whether it is getting segmented nicely. So I will say maybe 60% of the images were able to segment, but not all 100%. So a lot of times in our presentation, we show you the beautiful images, but that's not the real picture. But there are other lots of images which we don't show you because there are challenges and you don't get that beautiful segmentation. So whenever we show you, we are like magician, we just show you the good things, and not everything can be nice. But there was an attempt to improve it, and because then it gives us idea about improving. So what we realized, this can be a useful tool because this is simple, non-invasive, repeatable, quantitative, proven, and can be cheap because it can be integrated into the existing OCT machine. And therefore, Jay and I, we did a lot of work together from 2014 to 2017, around that time, and to understand what's happening. So just to give you an idea about what can happen in the choroid when it goes wrong. So in this thing, increase in the choroidal vascularity either can be because of the increase in the number of channels or increase in the diameter of the channels, as shown on these two cartoons. The decrease can be because of the loss of the vessels, either the larger choriocapillaries, the smaller one, attenuation of the choriocapillaries, or the loss of the bigger vessels. So one of that can happen. I don't know whether Jay has got into that to identify, but as of now, I'm not that successful in identifying which layer and what exactly happens. We can say that there is something going on wrong, but right now, not able to exactly say that whether which layer and whether it is increasing diameter and all. Probably that's something which I'm quite keen to kind of go in deeper. But as I mentioned to you that we had this term which was published in a letter to editor to Sonata's article about CVI. So that's about it. But then the journey started, and over a period of next many years, numerous articles were published, and one of the article which I'm sure Jay will remember in RO 2016-2017, which we published on the CSR, and that was one of the fastest ever article on the CVI where we got together and we got that thing. But many different conditions, more than 300 in less than 5 years were published, and you can see the impact it started creating. The one thing which is good about it, it is applied in a lot of diseases, but I get worried is this is not specific. So anything you put in, it's just getting CVI getting affected. So it is very non-specific, but can be a good sensitive marker, as we can see on this thing. So we had this journey. I'm not going to show you the video, but I'm just going to show you that the technical part of it. So started with ImageJ, which was still a very semi-automated kind of thing because there are algorithms which are written on the ImageJ and you to just use it. You're not doing anything new, but you're just trying to kind of come up with the steps how to use ImageJ. But there is a lot of integrated portions within the ImageJ which we use it. So a lot of people need to understand what is written there. So it was a manual. Then we went on to a little bit semi-automated. Then further improvement is the new protocols. So like medical retina, people like to call protocol. So we started calling it as a protocol A, protocol B, protocol C, protocol D. So right now we are the protocol D stage. This is again just to tell how the ImageJ used to work. We'll not get into the video of it, but as I said, that there are certain things which are written. So we were using nib black, but we need to understand what is nib black means. Why nib black? Why not Otsus? Why not other technique? So a lot of times when you kind of do, and that's what going to happen today is when you're going to use AI, you need to understand why AI is giving you something like that. So this is the AI for the imaging, when like a ImageJ, where you will just get something and you really do not know. So using this, we published some paper. Then we moved on to the bit of a semi-automated, where we created our own portal called a CVI.grid, but it's not existing. If you try to do this, this is now redundant because we moved on from CVIgrid.org, from protocol A to protocol B. Again, it was a portal where you can just go in and upload your image, and we will try to do some backend work, but still the segmentation of the choroidal scleral interface was done still with some bit of a manual attempt because there was still not accurate. Why it was not accurate? Because the interface itself to the human eyes cannot be seen clearly, and it was very difficult for the machine also to identify where it can be there, and we had a lot of errors. So if you put in the image and you think it's automated, no, you have to still correct a lot, and that will take a lot of time. So per image it was taking up to 3 to 4 minutes, and that's not what you want. So we moved on to another protocol. And under this protocol, again, as you will see, I'll just quickly jump onto the segmentation part. So this is the portal, and you can have many different programs, many different projects which can run parallelly. And but under this, the segmentation was happening using another kind of a protocol. So what we are doing here, thinking that the choroid is the part of the semicircle, a part of the circle. So we created two circles, one circle to lie in front of the RP, Brooks membrane, the second outer circle to lie at the CSI, the choroidal scleral interface. And then you truncate or you divide, cut off the rest of the part of the redundant part of the circle and just focus on that central little, the segmented part. And that gives you the exact choroid. So it was using the two circles. So you need to understand what is the geometry, and then accordingly you can think about it. So this was one bit of an innovation which we did. But again, it is still a bit of a manual work which you need to do. Sorry, I'll just take a couple of more minutes. And then we using this, we continue to publish in different, with the different collaborators and different things. We continue to improve on it, and then we came out with a little bit better protocol. And as you can see in this, but just very quickly, I'll show you. In this, we divided also the choroid into multiple layers, and parallel layers were coming, as you can see in this thing. But this was fully automated. One good thing was this was kind of fully automated. But what we got latest one, and that is not many people have seen, with the help of a third-year engineering student in Singapore, we developed a fully automated segmentation, which is giving almost 90 to 95% of the images we are able to segment, and we use some of the vision transformers. So these words are not that familiar to me. I'm trying to understand. So using a VIT model, and we are able to segment, and which seems to be good, pretty good. And very recently, on 10,000 images, it just finished the job in less than an hour. So Jay, something maybe interesting for us to kind of reconsider and reconvene and then see how we can do. The other work done by my collaborator, Professor Leopold, this is an independent work, though I've contributed very little in this thing, is artificial images. So he's doing some generative deep learning and came out with very beautiful paper and the work by him and Damon Wong, and using and coming up with the artificial images, coming up with the choroid. So you can't actually identify which are the real images, which are the artificial images, and then they apply the CVI techniques on that. And so this is the work which is happening in this field of it. So eventually what I want to achieve using this is to use it in my clinical practice, which we are probably there, but not yet because a lot of machines are there. I want it to be integrated as a part of my clinical practice. So that is where I want to achieve. With that, I'd like to thank the organizers for giving me the chance. Thank you.
Thank you, Dr. Rupesh. Jay, your comments on Sir's presentation. Mics.
Okay, Mike.
Thank you. Rupesh, amazing work as always. Yeah, you have been really the pioneer on this. So I think one of the things which we have learned over the time together is that it is means it was a very niche area that we never knew what we are looking at. But I think that as the imaging has evolved much more from where we started spectral domain to now where we are in swept source and with GAN networks and the diffusion models. So there is a lot to learn. The only thing I feel is that now we are getting more and more quantitative. The only unfortunate part in this journey of a decade has been that a lot of people have misinterpreted this biomarker. And the unfortunate part has been that people have been using imaging, coming up with the numbers which we know they are not accurate. So I think that as a community, we need to explain to each other that, let's not really get onto the inaccuracies, but instead just spend more energy and get to the closer one. The biggest limitation which I always thought of CVI is that we still don't have a ground truth coming from the histology, because we know histology can never be achieved in this manner. But I think that overall the imaging quality is improving, so now we are able to see much more like we have evolved. So it's still an ongoing work.
Yeah. So thanks, Jay. I just wanted to quickly comment about what Jay said very rightly about the literature and people misinterpret. What happens is some of these papers get published, and we are trying to do a systematic review meta-analysis on that. And there is a range, it's quite a wide range, and sometimes I see some of my papers also, there are some wrong information. It is very difficult to take out that information from the published literature. So if you're not quite sure, if you think something is wrong, do not publish, because once it is there in the literature, it will stay, and then whether it is in the whichever journal, so then it will affect people's understanding because people are reading it. When we do systematic review meta-analysis, you see so much of variations, and you really do not know to whom to believe, whom not to believe, and it affects people understanding and then the people who are practicing.
What is Haller's index?
Hilus?
Haller's index.
No, I haven't heard. Maybe we would have picked up the Hilus vessel. I haven't heard this. Maybe he would have known. But I'm not aware.
In earlier days, when we were looking into the choroid, and then we figured that the pachychoroid was just becoming one obvious entity. At that time, we started separating the large choroidal vessels from the inner choroid. So I think we published this maybe 6-7 years ago, where we were automated segmentation, where we are doing and separating the larger choroidal vessel, and that actually was one of the steps where we have now achieved, after 12 years of work, now we have achieved the 3D segmentation of the choroidal vessels. So now when we are now able to separate the Heller vessels, and where we have set up the diameter as more than 100, but we have still not reached to the medium choroidal vessels as just separate index, and we are still not there yet to image the choriocapillaries. So only the large choroidal vessels are in our hands so far.
Because many times the Heller vessels could be dilated and the choriocapillaries could be fine, and the patient could be sort of asymptomatic or uncomplicated pachychoroid. Till we can really image the choriocapillaries in a better way. So I think that could be, then only it could give us some idea.
Yeah, because these are the steps evolving. So the things will continue to change, and we'll probably reach one day. So I always see that things are evolving. Might not be that accurate, but at least there are steps moving forward. So I'm sure one day we'll reach one day, maybe in our lifetime.